Let me just respond to the problem around the pain coding, because particularly driven by long-term care, but also knowing where the Inter-I MDS was being implemented across the various sectors in the healthcare system. We had to make a decision early on, very early on, about what scales we would use. And we opted, and for some areas, we opted by simply holding our nose and going that way to go with the Inter-I scales, because while there's been a lot of research done on them in terms of reliability, validity, et cetera, they're not as useful in some cases for clinical care as some other scales. And I think pain was one of them, because we made the decision not to use the Inter-I scale in acute care, because the 0 to 10 is the scale that's used in acute care for assessing pain. And so we substituted that for the Inter-I in acute care in it, but it is the Inter-I scale that's that I think isn't differentiating enough among the different kinds of pain, but it's why we have them in there. Well, now we're open for questions or just discussion, and I think both questions coming from the panel as well as going to the panel. So, and if we finish this session a little early, lunch will be ready for us whenever we're ready for it. And Peggy White never lets us down, so Peggy, you got a question.
Well, I just wanted to say to Rosemary, I remember when we first did our pilot projects, and I went into a long-term care home up at Sudbury, and the nurses said, we never knew we had a problem with nausea. They started assessing their patients because they'd never used that scale before because it's not part of the Inter-I. They found out they had a lot of nausea, and they took me to show me this quality improvement board that they developed in terms of keeping patients up after meals longer. So I think when we start to assess these things like fatigue, nausea, that in fact we find that there is some fatigue, there is nausea, and so I think it really makes us look at practice. And I think for acute care that's so important because we have not done that routinely. The other thing about the long-term care database, it's mandatory to do that, or it's related to funding, and that's why we get good data in long-term care. And really, Ian and I, our goal is to work with sites to really get to that point of having all the data completed in acute care. And that's really what we've been trying to work with sites to just, you see how valuable this data is. It's important that we have good, complete data. That's really all I wanted to comment about.
Questions? Walter's working his way toward the mic.
So I'm very impressed. Thank you. Like that's quite certainly a much more fulsome look at the data than we've had a chance to do. So hats off. Kevin, I think I have a question around the pressure ulcers. You raised the question. You know, I love the blame game. You know, for pressure ulcer management, when like, you know, maybe we should just manage the pressure ulcer. But I'm wondering in the data, so one of the, I didn't actually put it up there, but one of our indicators is there wasn't one present on admission to acute care, but then there is one present on discharge. So I've wondered if, so I have two related questions here, if you've looked at that as opposed to just the prevalence, because I think we have about 2.2% prevalence, so that would tell me about a third of the pressure ulcers that you see in acute are starting in acute. So I think that would be one start at getting this, and then also then looking at the discharge patterns of where are people coming from and going to, if you looked at that at all, for admissions from long-term care, for example, where, I mean, for functionally impaired people, they're at much higher risk for having these, and just a question around that.
I think the mic is on. Okay, Yeah, we're on. Thanks, Walter. I think we did look at the pressure also on emission and also upon discharge as well. The problem is some of the quality of the data, and also in terms of the it's not always captured, and there's some double dipping as well when the assessor was actually documenting the occurrence of pressure ulcer. So I think we need to go back to take a look at the data again. We did look at the incidence, what we call incidence anyway, in terms of the person did not have a pressure ulcer, and in this quarter they developed a pressure ulcer. So we did look at that we classify that as an incident rate for different sectors. Did I answer your question? Kind of, in some ways.
I'm going to have you introduce yourselves. Okay.
I'm Julia Scott from Grey Bruce Health Services, and my question is for Linda. I wonder, can you tell us a little bit more about your study that you're working on about the relationship between nurse staffing and outcomes? I find often that I think this would be great for nurse administrators, because one of the problems with using research studies that are written and are maybe based on US data or older data is it doesn't really help you in the moment. And so I'm really interested in what you're working on.
Certainly, Julia. As I indicated earlier, we're just in the process of starting the data analysis and running the first sort of waves of it. Essentially, like I come from administration myself and was always interested in looking at the links between nurse staffing models and different models of nurse staffing to clinical outcomes. And we didn't have the outcome database to allow us or enable us to be able to do that. And so as we worked on developing the HOBIC database, Walter and I were very much focusing on what can it do and what will it allow us to do. And so a couple of years back, I think probably with maybe 2008 data, we ran a preliminary analysis and there wasn't really anything there yet. We didn't probably have enough data in it. So as more data comes in, and as Walter was indicating this morning around how many sites and different sizes of sites, large and small, it will improve our ability to test some of these models out. And so my sense is I'll be able to do this a number of times over time. And so literally what we're looking at in a lot of the nurse staffing literature or nursing literature linking staffing and outcomes, it has been percentage of RNs only. And when you look in Canada and in Ontario, there are not many sites that have 100% RNs. And in fact, all of our staffing models are moving to more mixed models. And down the way, even models that go beyond our licensed or regulated nursing staff. So where I'm leading and leaning is toward, first of all, we need to figure out what variables, like what's the best staffing characteristic that we can test at acute care, then maybe in long-term care, when I hear now where Joan's trying to go. So we need to just start parsing that out and looking at that. So right now I'm looking at all kind of care workers that by linking the MIS database to this, so all providers that provide nursing care, RNs, and then RNs and RPNs as blends. And in 3 of the models, I think we've got the whole workload or weighted case piece in there. So that's what we're trying to do in terms of just, it's a first step. And so it's almost a 2-stage process. Like we really need to figure out what staffing variables we can be using. And it's not just then variables that all use, but I think certainly in a lot of the research we're seeing emerged from the Queen's Posse, it's the kind of thing that other people will be able to use as well in their studies. So it's the first one that we can do, that we've been doing, essentially linking to some of the traditional outcomes research that you've seen coming out of other centers in North America.
I don't need that, I'll use this one. I'm wondering, Linda, if there's any chance going forward, if we can begin to look at the differences that increased proportions of baccalaureate prepared nurses are making. I know some of the Aiken's work and some other folks in the US where they've looked at institutions with different proportions of baccalaureate prepared nurses, and some in the community as well, where some of the patient outcomes are better with increasing proportions. I'm an very old nurse educator, and I lived through the not really battles, but the pressure to move to baccalaureate as entry to practice. You know, we all celebrated that when we got it in Ontario in 2005. So the education system changed quite a bit as a result of that. But I haven't been very aware of changes in delivery models in terms of the practice environments. And I don't know whether or not you can see the impact of increasing proportions of baccalaureate. I think last year, 40% of practicing nurses in Canada were baccalaureate prepared. I think Nova Scotia was higher than that. I did a bit of work in Nova Scotia, and they were closer to 50%. But I think I wonder if there's an opportunity to look at whether we're seeing changes in patient outcomes with an increasingly better educated workforce. I think you can't divorce that from the experience of the workforce and whether you have access to data that would allow you to do that kind of study.
It's a really good question. It is one of the areas that I'd like to explore going forward, like beyond the staffing variable alone, because a lot of the work that we are seeing emerge out of our counterparts in the US is that it's not usually just one thing. It's the work environment is bigger than staffing, and we need to look at a constellation of characteristics. Now, I've been on a thesis committee for a doctoral student that was actually trying to capture staffing variables, and Walter and I need to look a little closer at what's available in there. And the experience I've seen so far in the data set that it wasn't always captured, but we haven't actually looked at it ourselves to, I don't know if you can comment on that, Walter, no. But it's certainly an area we would be interested in going, for sure, and it fits with a lot of what's happening in the nursing work environment. And there's also other variables in terms of work environments that we might need to look at capturing. And so I think down the line, are there other databases, are there other things that we can look at linking towards as well? Thank you.
Ruth, hello.
Hello, my increasingly younger looking dean. It's amazing how good you look compared to last year.
It's because of the distance between us. I look good at a distance.
I think the reason is that her student's getting older and my eyesight's not as good. But actually, I think you look fabulous wherever we look at you. So joking aside, my question actually is for Dr. Kim Sears. As we know, medication reconciliation is one of the ROPs for Accreditation Canada, and as administrators, that's where the attention is going to go, your accreditation ROPs. So my question is, how can medication safety capitalize on that piece of work that most hospitals have to do now, is looking at medication reconciliation and how we can compare the two and somehow capitalize the strength of both?
Well, I think the problems that some of the organizations are still dealing with years after medication reconciliation has come on board is how are they doing it effectively. And I know that for some of the smaller sites, if we're looking at hospitals, so some of the larger sites might have a pharmacist or a nurse working together, or a physician in charge of the med rec, or taking a lead. And then there was some smaller sites that said, we don't even have a pharmacist in our hospital. We have very limited nursing. We can't get, it's a challenge. And I think until some of the system issues are ruled out and people know how to do it effectively, thank goodness it's mandated, and that's one benefit. But the problem is too, we never know where people are going. And so they might see an emerge, they might have their medications reconciled if they're in that emerge, but then they might use another emerge. So the system is complex, and people aren't always accessing care in one place. And the one place might not have their systems in place to effectively perform medication reconciliation as well as they'd like. So I think there's still work to be done. Did that answer your question?
People take, right?
Yeah.
So this is your home medication list right there.
Yeah.
So that's why I'm saying that why can we not capitalize on the strength and the ROP that people must do, and how can we make that data available and link the two if possible? Because
well, I think there's a huge area for advancement, and I think what Dot mentioned coming in is that you're really going to be looking at discharge medications. And I think that there's an area that's untapped that we really need to explore further. But I think there's a lot of complexity if people aren't even aware what they're taking to even come to emerge with a bag or with a list or with anything. And care providers that are working with them, family members, may not even know the list that their parents are on. So there's a huge area that I think HOBIC can help bring out some of the issues for, and say, you know, with the ROPs and with Accreditation Canada, this has to be done. And so I think there's area for advancement, because if we don't advance the area, we're going to have a lot of these people repeating to emerge with medication-related issues.
yeah, that's exactly what I'm getting at, that
Yeah.
how HOBIC can be, you know, the driving force.
Yeah, I think so.
Capitalize on what's out there already.
Yeah, I think it's a good point.
But I have to say, and certainly Walter referred to this earlier, I think of all of the areas that I'm concerned about, it is the low number of completions, particularly of therapeutic self-care on discharge. And I truly do appreciate all of the difficulties around that in terms of the amount of notice a nurse has before a patient is discharged and trying to get the patient prepared. And I think increasingly, well, you know, we've probably known for a long time, but I think the research that's pounded this in is more recent, which is just telling a patient is not any guarantee that the patient is going to learn about what their medication is. It's got to really be driven by the patient around, and the nurse has to feel assured because of the question she asks the patient about, you tell me, you know, after we've been through the teaching, you tell me now what you're on, what you understand they're for. So there's some validation of that. And that takes time, and it does take some planning on the part of nursing. And I think it's just a big area that I don't think we've got our heads around yet about that discharge preparation, and how much, in fact, that is dependent on nursing. And we can make a huge difference in that area. And it's somehow in terms of how we deploy nurses and how their workload is organized, the importance of that preparation for discharge has got to be given very high priority. And I think that the data that we saw with the low completions, I think it's not acceptable. Small hospitals are really doing very well. We learned that when Peggy and I were going around and meeting with the folks from the small hospitals, and the very creative ways they were using this information, and where the nurses were using it to link with physicians because of everybody knowing each other. It's an advantage in small hospital environments. But I think it's a real challenge for larger hospitals, and the pace and the demands. But it's just one of those where we've got to go to priority. Absolutely.
We were at meeting not long ago, and we were talking about the complexities in safe medication delivery in a hospital, and somebody said, you think there's complexity within a hospital. Wait till the hospital sends their patient to home care, and home care has to try and communicate with someone at the hospital that we don't even know who it is, we can't find them, we don't know the orders. Like, it's just such a complex system that we're in.
Yep. So, does anyone have a solution to that? So, are there any other questions? Lynn, you have a solution.
No.
Lynn Nagel.
Hi. But Peggy and I have talked about this in the past, and Sally and I were just talking about it. Not that this is a panacea, but I think we have another whole venue of opportunity to do some research, and that is in the space of technology design as we're starting to embed those tools more and more into clinical environments. And I mean, just experience being a patient and being on the closed loop system of medication delivery, it was very apparent to me that there's some tremendous benefits that are being realized because of some of these tools. And I know from the work that I've done over the last many, many years that most of the systems out there as yet are still very poorly designed. And I'm not saying that the best designed system is going to get complete documentation, but I think it goes a long way to help. So I'm too old to do the research, but I'm sure there are some young people in this room who could see a whole career path ahead of them, because I think there's great opportunities. The posse. It's yours.
But again, well, I think it just reinforces what I said earlier about the huge leaps forward in technology design that we've seen since we started with HOBIC. The types of instruments available to us, and just the way the questions are designed and built into these instruments. I don't have the right language even to describe it, but in any case, I think again, and I think I just don't know whether we have enough nurses working with the technical folks to be driving to get it as user-friendly and useful to nurses in order for them to do what they need to do with the patients. Any other questions?
Want to make a comment. I think I think your point is well taken. The problem with nursing right now is, yes, we can do the documentation, do assessment. So what? So yes, there's workload issue. So what? So who's going to listen to the data? How is that going to inform policy changes? And are we going to get more money into the system to support the workforce? So I think people are a little bit disengaged or disenfranchised because, yeah, we can come up with great data and document, but no one is looking at it. Well, we are looking at it, but we need to help them to get some money and get some support.
I think the answer to that, Kevin, is nobody's looking at it yet. We're still very much creeping up to where we need to be on the utilization of HOBIC. First of all, getting it into facilities, getting nurses comfortable with it, and really, excuse me, seeing it. I've had this cold for a month, and if somebody's got a solution to that, I'd like to hear. But getting it as part of nurses seeing this as critical because of the information it provides. And I think we've got to get there, and it's complex because nurses have to see the value of it and its use in order to do that. So it's a bit of a vicious circle, but it is getting better, I have to say, from what we've seen over the years. I seem to be talking an awful lot about these quality-based procedures. when we were looking at, we had terrific data to work with, a lot of it from ISIS, but the ministry is costing out all of these things, hospitals, for the 30 procedures that are going to be part of these quality-based procedure, 30% of the funding that will go to hospitals. But we looked at, to the extent that there was data, how it broke out. And 60% of the cost of those procedures that we were involved with, the congestive heart failure and COPD stroke, 60% of it was nursing. I said, God, 60% of these costs are nursing. They said, yeah, but a lot of that is length of stay. I said, yeah, okay, that's part of it. But relative to everything else, there's huge dominance of nursing. And we don't have any information about, we couldn't go anywhere with that. We couldn't drill down into it around what is that being spent on. And I think, again, so we're hamstrung by lack of information, and we have to work our way through this, and I think working with the ministry. HOBIC is funded by the ministry. You know, this, they own this more than anybody else in the province, and I think this linking that we need to have the information that's contained in that 60%, and we have to have it linked to how that influences patient outcomes. And we don't have that now at all. And we don't know if you shift some of that 60%, and this is the kind of stuff you do, Linda, if you shift some of that 60% to this or to that, what do we get in terms of outcomes? Do you get nurses with more time for patient discharge so that, in fact, patients are better prepared, and hence you'd start driving down your readmission rates, and you can begin to see the loops. And here comes Peggy.
Well, I just wanted to say one more thing along that line. It is, I mean, it's not always about money, like needing more money. It's about how we look at practice, and I think that HOBIC will give us some evidence maybe to look at practices that we're doing that lead to improved outcomes, and maybe some things that we're doing that really have no benefit. And I also think it gives us information to really start looking at where we prioritize care. So Leanne Jeff's work looking at HOBIC scores and admission as predictors of ALC and length of stay. So if a patient comes in with a need around function and fatigue, kind of directing our resources at the front end rather than at the back end when they don't go. And I think that's how we have to really start thinking about and using information. So it's about resources, but it's also about how we use the resources, and really what evidence is really leading to, what practice are we doing that are really leading to improved outcomes. And I ultimately think, and this is down the road, but you have to sometimes look down that road, to give us data to look at what teams produce better outcomes. Because we haven't really had that evidence, and maybe for a stroke unit, we need a different mix of team than what we have to produce better outcomes. And maybe for a cardiac unit, we need a different mix of team to produce better outcomes. And that's where we need to get to in terms of looking at practice, in terms of should an RN do this? Does it matter if an RN or a PSW under the supervision of an RN does it? Should a physio do it? Who produces the better outcomes? And that's where we need to start in collecting outcomes, and HOBIC's just a little piece, but getting us to have data to support some of those questions.
Well, I think the silence means we need lunch.